Hi, everyone. Welcome. I am Julie Melk, the Outreach Manager for Balance Eating Disorder Treatment Center located in New York City. If you are here for students and eating disorders, how eating disorder treatment and schools synergize, you're in the right place. The nature of today's event, I will call it an event, is conversational. So we encourage you to put comments in the comment section, to use the Q&A button at the bottom of your screen. Either way, though, we'll be sure to draw you into the conversation and answer any questions or share your comments. We'd love to know where you're located, how you heard about this event. And we'll get started in just a minute. The flow of today's event is going to cover the scope of eating disorders in the school age population. I know that's very expansive. School age can really be at any age. And we will talk about how school and treatment can coexist. We'll dive into who our amazing panelists are first and why we've chosen this diverse panel to inform you and to share with you about what their experiences have been and also how we've all collaborated with each other from our different angles and perspectives working with school age individuals. Liz Sinclair is on today as my co-moderator. Hi, Liz. She's going to man our slides today, so you might hear me say, next slide, Liz. Feel free to put in the chat or in the Q&A before we dive into going through our slides and our questions that will draw forth from the panelists ideas of how to collaborate, how to identify, of course, what are tools that you can take with you for you and your team? But I would love to hear from you in the comment section what you're looking to get out of today's conversation, because we're happy to make sure that we address that. All right, Liz, if you want to share your screen and we'll get started. Again, the topic today is students and eating disorders, how eating disorder treatment and school synergize. Welcome to this panel discussion. My name is Julie Melk. I'm the Outreach Manager at Balance Eating Disorder Treatment Center, which if you move to the next slide, I'll talk a moment about what Balance is. It's a premier eating disorder treatment center offering boutique outpatient treatment options using evidence-based practices. We will talk about each of our facilities in more detail at the end of the discussion. So who's with us today? First, I'd like to introduce Melainie Rogers. Melainie Rogers is Balance founder and CEO. She's a certified eating disorder registered dietitian. She's the co-founder of New York's iAdapt chapter, International Association of Eating Disorder Programs. And as I mentioned, she's not only the founder of Balance, but she's also the founder of Redefining Wellness. Melainie is also a professor in the Department of Nutrition and Food Studies at New York University. Welcome, Melainie. We also have Dr. Evan Flamenbaum, and Dr. Flamenbaum holds a doctorate in clinical social work and an MA in school counseling. He's the head of school at Academics West. He's also the co-founder of Therapy West and co-created Clinically Informed Academics, CIA, a research-based model that provides a framework to improve the overall functioning of students' social, emotional, and educational health. Thank you so much for being here, Dr. Flamenbaum. And finally, we have Denise Limongello, and Denise is Monte, Nido, New York's Regional Outreach Manager. Denise is a graduate of the Columbia University School of Social Work, and Denise began her clinical career at the Renfrew Center of New York. Currently, Denise serves as Monte Nido's Regional Outreach Manager, and she also has a private practice of therapy for eating disorder specific population. Welcome, Denise. We're so glad you're here. Thank you, Rachel, for your question. I'm curious how approaching eating disorders with adolescent girls on the autism spectrum may differ from neurotypical school-age children and adolescents. It's a great question, Rachel. We'll make sure that we get to that. I'm sure, Liz, you'll keep track of that. And that's something that we already have planned for. A brief introduction to myself is part of the Balance mission to support professional and client audiences through education and awareness. I organize collaborative conversations such as this among experts in the field of eating disorders and mental health. So what are our objectives today? First, we will learn what common misconceptions about eating disorders there are, and how to detect early warning signs. So first we'll define, of course, what are eating disorders? What are we talking about? And then we'll leave you with a great understanding of what is eating disorder, perhaps prevention, and what does that look like with your certain population? What is eating disorder emotional support and a school's collaboration with an eating disorder treatment center? We also hope that you'll gain actionable tools, ways that school can support eating disorder recovery and help prevent relapse. So why are we here today? We always want to start with why have this conversation? We highlighted a few points. I think that there's probably even more that we could elaborate on as to the importance of having this conversation today. But first, school demands, along with genetics and maladaptive coping behaviors, can create a perfect storm for an eating disorder to develop. And we'll talk a little bit about, of course, how an eating disorder develops and identify what exactly in the school environment and an individual in that environment with particular characteristics and traits might exacerbate their coping to be maladaptive and result in disordered eating. We'll talk about the importance of early detection. I think we'll talk at great length at this. And we know that school professionals spend large swaths of time with individuals, sometimes more than the family unit is together. And so how critical your rapport is with individuals in identifying and having conversations. And lastly, an eating disorder can dramatically impact school performance and engagement. And we'll look at that relationship and how it's cyclical and sort of which came first in terms of the chicken and the egg. Did school performance go down and something result from that, or was it just the opposite? Next slide, please. So eating disorders, myths and facts. What is an eating disorder, right? Mel, I'd love for you to dive into this and share with us what is an eating disorder.
Thanks, Julie, and thanks for that lovely intro. Welcome, everyone. We're really thrilled to be here today. So an eating disorder, if I really kind of keep it at its simplest form, eating disorders are a cluster of behaviors that are motivated often by a drive for thinness. We're also seeing eating disorders among some of our younger boys where the predominant motivation is towards bulking up. So we've got a drive for thinness and we've also got a bulking up. And what happens with that cluster of behaviors is that it becomes a very, very obsessive focus on food, calories, weight, and body shape. And it becomes not just obsessive, but that obsessionality, if you will, gets to the point of being very distressing and very time-consuming. And for a full-blown eating disorder, we see it where it gets to the point where it's disruptive to daily life. So for our kiddos, that means school starts to suffer, relationships start to suffer, families start to feel the tension at home. And so we really see impairment at the level of a full-blown eating disorder. I will say that there also are some eating disorders that we're seeing now in relation to the question we had earlier in some of our more neurodivergent kids, where it's not necessarily the motivation isn't necessarily a drive for thinness. There are sensory concerns that go into almost a disgust, if you will, with certain foods or textures. And so we are looking at, and we'll discuss those a little later, around some of the sensory motivations where kiddos may back away from food and struggle with weight loss, and then medical and psychological consequences as a result of that. So in summary, eating disorders lead to majorly impactful medical concerns, majorly impactful psychological mental health concerns, to the point that, unfortunately, eating disorders have the second highest mortality of any mental illness. So we're talking about something pretty serious here. The good news, though, that I want everyone to know and leave with today is that eating disorders are curable. They are absolutely curable. People absolutely recover. And the beauty of speaking to perhaps school people who are involved in schools, professionals who are maybe seeing younger kids, is the quicker we can diagnose and treat someone with an eating disorder, the better the prognosis. So we're actually in a really opportune window, given the age of kids, with that, if there's an early development, we can get on top of it quickly and hopefully lead to a really, really great outcome in a shorter period of time. So I hope you all leave with that sense of hope from today's presentation. Back to you, Julie.
Thanks, Mel. I really appreciate you two talking about the severity. That was going to be one of my questions. How serious are eating disorders? And I think that might be a common misconception, is that they are not. Before we move on to misconceptions entirely, Mel, what have you seen in terms of the prevalence of the incidence of eating disorders happening nowadays?
Yeah, it's a great question. Historically, we thought that eating disorders were quite rare. And if you look at some of the research, it does suggest that. But we now know that 10% of the population has a lifetime prevalence to develop an eating disorder. 10%. So in America, that's at least 30 million people. And that's not even talking about disordered eating, which is kind of, the stage before, which is even more prevalent. So these are far more prevalent than we ever thought. The difficulty with eating disorders is they are not necessarily obvious. We all have that image, I think, in our mind of an eating disorder is a skeletal looking young girl, but that is a very rare example. Most eating disorders, kiddos or adults, you wouldn't know that someone was struggling, and that invisibility is also what leads to the difficulty of realizing someone has an eating disorder and then helping them to get treatment.
Yeah, thank you. Let's talk about perhaps what they are not. And Denise, would you share with us some common misconceptions that you know of eating disorders? And then to follow, perhaps Dr. Flamenbaum, maybe you've observed common misconceptions that school professionals have had around eating disorders specifically. Denise?
Yes, absolutely. Thank you. Thank you for the welcome. And I'm delighted to piggyback off of what Melainie just had to say, because she really stressed the importance of full recovery, which is definitely the message we get from Balance, and we are clinically aligned with that at Monte Nido, that full recovery is possible. We definitely embark that to our clients as well. So I love that you mentioned that, because it gave me an opportunity to point out how clinically aligned we are as facilities. Common misconceptions. I absolutely love this topic because there just are so many. So I'm narrowing it down as best I can. But I can even echo what Melainie just said. The face of an eating disorder is usually, the misconception is this frail, skeletal, maybe even prepubescent and often white girl. And girl, emphasis on that word too. And that is completely misleading and grossly unfair, because eating disorders come in all shapes and sizes, all different kinds of variation of symptom use, straight size bodies, larger bodies, smaller bodies, men and women, trans, non-binary clients and patients. So I remember actually when I first started working in program a very long time ago, I was speaking to a patient at that facility who said she felt always tragically misunderstood. She was a woman of color, saying that this was a white girl's disease. And it's not a white girl's disease. It's not only a girl's disease. It's an everybody condition. So so completely inclusive, does not discriminate. So I want to start with that because I've always felt it's grossly unfair to people of color and to men and boys as well to say that it's a white girl's disease or that it's just a small-bodied anorexic centric symptom set. So then I can get into more specific myths about certain behaviors. The myth of anorexia, this comes up all the time in my private practice as well as at Monte Nido. The myth of anorexia is that patients and clients struggling with anorexia simply don't eat at all. And that's not true. They eat in a very specific, restrictive, ritualized kind of way, but they don't not eat at all, because I have had so many experiences where the patient or the client is in front of me and they're trying to tell me they're not struggling with restriction, they're not struggling with anorexic symptoms. And when I ask them why, the answer is because I eat. And it's like, okay, but you may eat in an incredibly restrictive, ritualized kind of way. So that's a myth. Also, a myth about specific behaviors of different disorders and symptom sets is that bulimia is only self-induced vomiting. And that is not the only symptom that we see with bulimic patients and clients. Bulimia can take on the form of overexercise, it can be self-induced vomiting. It can also be laxative use, fasting. Basically, the bulimia is a compensatory behavior. It is a deliberate purge and expunge of food consumed. So it doesn't really matter what the behaviors. I mean, it matters in terms of there's different impacts health-wise to these different behaviors, but it's all sort of under the umbrella of a purge or a bulimic behavior. So that's something I always like to clarify as well. I think also it's very important to when I'm introducing Monte Nido to explain to people, because there is so much anorexic centric thinking, when I talk about our residential facilities at Monte Nido and Clementine, which is the adolescent division, oftentimes people assume we are just treating anorexia in the house, and we are treating all of the disorders under the same roof. So that is, yes, it's anorexia, different kinds of anorexia, bulimia, OSFED, ARFED, binge eating disorder. Binge eating disorder is another disorder that people have a limited understanding of. When people talk about binge eating disorder, they often think that it's just this episodic experience of consuming a large quantity of food, but binging is really often an umbrella term, which refers to any eating that is not in response to physical hunger. So sometimes in a very sneaky way, binge eating behaviors can take the form of grazing or just sort of compulsive overeating at meals, and not having it be this measurable episodic event. And also there are misconceptions thinking that people who struggle with binge eating always live in larger bodies. That's not true. Also, it's what I have found to be one of the most prevalent misconceptions in my private practice is that people don't realize that those clients and patients who struggle with binge eating disorder are often in the most restrictive mindsets. So the binge can sort of serve as a failed attempt at restriction. So there are a lot of ways in which I love working with this population, because I feel they are often tragically misunderstood. Continuing on the theme that I was just talking about a minute ago, that we have all of the disorders being treated under the same roof, that is of enormous value and clinical importance, because we're trying to teach everybody that it doesn't really matter what you're doing. It matters health-wise, but in terms of your recovery, it's it's just a different behavioral expression of how you are coping with the conditions that have led you to these behaviors. So those are, to me, the most important bullet points on the misconceptions.
Thank you, Denise. I learned a lot in just that few minutes time. Thank you. Dr. Flamenbaum, did you want to contribute any maybe personal misconceptions that you've had or that you know from, a school professional environment?
Well, I see one misconception, which I see often as a motif in the mental health world and certainly the world of education, which is people want to blame the family. That's like kind of like a default position of a lot of people. And I think it's important. Eating disorders are complicated. Eating disorders can be hard to treat. And like Mel said, mortality rates, recidivism, like it's serious. And it's really important that people understand the etiology of them, which is, yes, there is certainly a strong genetic component. Mel, you probably know the data about first generation, first degree family member having it, you're much more likely. But, it's got a genetic component, biological component, cultural component, social component, psychological. So it's just so easy to blame the family. And that creates all sorts of other treatment interfering issues that go on. A matter of fact, from a school perspective, and I'll say this about schools in general, especially private schools, a lot of private schools want to blame the parents for everything, honestly. And it's almost like this socioeconomic countertransference. You have, typically some very affluent families, and you have people in the education field, and it's just so easy to look at this as like a rich thing, or you have bad parents, bad families, and it's a vast oversimplification. And I think we have to educate everybody working around these kids to understand if you think of it that simply, you're not going to be very effective about supporting it. In fact, schools should serve as the bridge to families. We're the place of identification. This is where kids live for, a third of their, let's say half their waking life. They're at schools, and schools need to, staff need to be trained on how to communicate this with parents, how to bring them into this. And then obviously we'll talk all about how you create these sort of treatment teams and integrate all the components of a student's life to create this united treatment front, which I assert it really increases better outcome. I mean, that's commonsensical, but we'll get into more of that later. But that's the first thing that comes to my mind, is this reflexive family blaming kind of option that people jump to.
It's very enlightening, Mel.
Yeah, sorry, I just wanted to echo that, Evan, absolutely. And, if there are any parents who have joined us today, we do know that has been a horrible practice historically. And absolutely, I want to echo exactly that, Evan. It is not parents' fault, and they can be incredibly helpful in the solution of that. And also for the parents out there, no parent, I'm a parent myself, none of us are given a manual once we become a parent that says how to respond and identify an eating disorder in your child, and here's what to do. So, I just want to kind of have some compassion there for parents out there who may find themselves in that situation.
This is a perfect segue into our next slides, which are a brief overview, Mel, if you wouldn't mind, on the types of eating disorders, which then parlays. And so how does an eating disorder develop?
So an eating disorder, as Evan said, the etiology, we call these biopsychosocial illnesses, bio meaning biological, psycho meaning psychological component, and social, the social pressures, the current culture, the immense pressure to be thin and body image, etc. Those are all pressures. So, and then there's a genetic piece. We believe now that the hereditary factor for an eating disorder is around 70%. That's very, very high. That doesn't mean that, let's say, dad has bulimia, so my son has bulimia. It doesn't show up as clearly as that. It's more that there's a genetic propensity in the family that the brain responds to food or the absence of food in a certain way. And so those traits of responding to food are what are inherited. And we often see a cluster with, say, disordered eating in the family, if not full-blown eating disorders, and anxiety and depression, and then personality traits. So there's a kind of a cluster of things that tend to go together. So that's a little bit about the etiology, which means that if I just walk you through some of the types, then many of us are very familiar with anorexia nervosa. It was the first eating disorder to get a diagnostic code. Restrictive type is probably the most commonly known. There is a binge purge type as well. And now we also know there's something called atypical anorexia, which is not atypical at all. In fact, it's the most common form of anorexia, but you wouldn't necessarily know it because clients or people who struggle with atypical anorexia usually start at a higher weight body and lose an enormous amount of weight, but their end weight is still what one may regard as a slightly higher weight or even just a normal body shape. So they're not moving into a rather undernourished state. So very, very invisible in that way. And honestly, in our society, our clients with atypical anorexia are often celebrated because it means they got the dieting right and they've done a marvelous thing. What we are now realizing is they also have massive medical complications, psychological complications, and high mortality. So let's be careful about when we're celebrating our next family or friends' massive weight loss. It could be atypical anorexia. Bulimia nervosa is when there's a lot of restricting, but then there's an overeating episode. And I think Denise did a good job of talking about the purging piece. Binge eating disorder, this was the last eating disorder to receive a diagnostic code, and that was in 2013. So honestly, the research around this is only starting to get put together. But binge eating disorder, again, I'm going to use kind of general terms, is when a client is restricting and then has an overeating episode, usually feeling very out of control, eating a large amount of food in a short period of time. That's the hallmark of an eating disorder, binge eating. And clients with binge eating often gain weight over time, not always, but often. ARFID, now we had a question earlier about neurodivergent kids, and this is where ARFID also has been more clearly identified. This used to be called picky eating, but it was picky eating that kids didn't grow out of. And it was picky eating to the extent that kids started to lose weight, fall off their growth charts, and then ended up with, again, significant serious medical and psychological complications. So ARFID is an acronym that stands for Avoidant Restrictive Food Intake Disorder. And this eating disorder stands alone in that it is not motivated by body image. It is a food aversion that leads to a reduction in intake, which leads to weight loss. So it can look like someone might be obsessed about their weight, but they're not, and often are very, very embarrassed about the weight loss. So we often see this in kids, and more predominantly to know in boys. And there's an overlap, as we said, with kids on the spectrum in particular as well. And then OSFOD, which is just other specified food eating disorders. That's just a catch-all term for anything that doesn't fall in the above categories. So those are the types of eating disorders that we now understand. And I would suggest that over the next 10 years, we'll be able to pull out more subtypes within these categories as we learn more.
Thank you, Mel. Very informative. We touched on how an eating disorder, or really Mel expanded on how an eating disorder develops. I would love to know, Liz, you can move to the next slide. Not only is a school impacted by an eating disorder, but is there a typical student profile that can be associated with someone who has an eating disorder? Denise, do you want to take on that one?
Sure. I was at the first. Are we starting with the previous slide, which is how does an eating disorder begin? How does it develop?
I think, no, we talked about that at length. I would love to know if there's a specific like student profile, that is associated with someone in school that has an eating disorder.
Sure. Absolutely. Yes, we did do a wonderful job of describing the collision and how parents often get blamed. And so I'm really glad we went over that. And then getting into the profile of I guess the type of students we see who are candidates for eating disorders. The research definitely shows that often high achieving students are impacted the most. As time has gone on and I have spent so much time working with this population, I'm sort of seeing in not only in my practice, but at Nido as well, that it's more than just the high achieving profile student. It's kind of, it kind of ripples into everybody, but definitely students whose worth and self-esteem is tied into their achievements are often the people whom we see who develop eating disorders, people who are competitive academically, athletically, heavy on extracurricular activities, usually students who are really on a steadfast track to get into a good college and don't have a guarantee that they're going to get in. This can be an avenue for control, for some, it's a behavior and something they can take on that they can sort of predict the outcome better than they can in school or extracurricular activities and athletics, even if they've always had success in those other arenas. So that is usually what we see. But I also have seen over the years, it just ripple into all kinds of students where just anyone who is self-esteem is struggling, who's struggling with depression, who's struggling with anxiety, and among other conditions. Also, school is often an extremely stressful place. They have academic stressors, we have bullying, we also have online bullying, which is a more recent phenomenon than I grew up with, because bullying sort of took place during certain set hours. It now continues all day and all night via the internet. So that's another thing that we see. And also another stressor, in addition to academics in schools, is popularity contests too, that are taxing on a student's self-esteem.
Really helpful. Thank you, Denise.
Sure.
Dr. Flamenbaum, I think this question can be interpreted a few ways. Is school impacted by an eating disorder? So is obviously the school and the system itself, the individuals within that system impacted? And then for the individual with an eating disorder, is their schooling experience, right? Performance, engagement, socialization, is that impacted by the eating disorder? This is also going to lend to warning signs, right? And what we might be seeing. Oh, you're muted, Dr. Flamenbaum.
Take off the lens cap. Here I am. That dates me, doesn't it? So schools, I mean, basically what Denise is saying, schools are possible, I would say, the primary spot where this plays out. This is where you have your sports, your athletics, your social interaction. This is where you eat lunch, often breakfast. So there's food intake. So much of this plays out. So it stands to reason that schools really need to, again, there needs to be policy created. And so, like, for example, bullying, obviously schools have policies around bullying. Bullying has created a tremendous amount of problems, especially through social media, that has led to, higher mortality rate. But I also think that bullying policies in schools need to really also emphasize to the people who are implementing the policies, if there's any bullying surrounding weight issues or appearance issues, that gets more, pardon the pun, that gets more weight. That really, you have to understand there's like flags that just need to be communicated. I think where schools do well, if they have good policies, good staff and student training, which we can talk about how to do that, then you can catch a lot of these warning signs. But, you know, if you also think about what Denise said, some of these behaviors are not just, they're adaptive, if not celebrated. We want our kids to be A students. We want them to take 9 APs and play 4 sports. I have a daughter who's a junior in high school and a lovely, wonderful, healthy kid. But she is, the split screen of me at 17, in addition to having hair in that split screen, it was a much lower demand. And they've done research on like 30, 40 years of what the demand of schools now compared to then. They have so much demand and expectation. So it's like the successful kids actually engage in certain activities that might look adaptive, but like Mel said, covertly they're a problem. So think about what schools can observe. If it, again, they're not, you have to look at these things in aggregate and over patterns, but if you're skipping lunch a lot, if you see a kid, you know, seeking out snacks all the time, again, not at face value, but patterns in the context of other behavior, throwing away food, secrecy. Again, if you're spending 7-8 hours around these kids and schools are good at sharing information as part of their policy sort of structure, you're going to catch this stuff. Using the restroom immediately after eating, like that's something we look at Academics West. And I think one of the strongest indicators, and I'd love to hear what my panel mates, I just made up that word, have to say, is seeing kids who weigh themselves. Like that to me is a really loud alarm. And it's a big, but obsession with working out, again, yes, like Mel said, the boys bulk, preoccupation with diet or exercise. These are all, again, these are like such warning signs. And if they're not communicated to the right people at school, you're really missing a tremendous opportunity for early intervention. And again, like we said, early intervention exponentially increases a better prognosis, better outcome. And so schools are probably the most important place to understand how to identify and support disordered eating and eating disorders. That's my thesis, and I think it makes a lot of sense. Integrated into health class. There's all sorts of ways to do this, to do it right, and it really should be a sort of a national initiative at this point.
Thank you, Dr. Flamenbaum. Mel, anything that you'd like to contribute in regards to behaviors or, you know, what someone might see in school performance, physical indications?
Honestly, I think it's been captured so well. And I would like to say, though, I'm so impressed, Evan, that you all are on top of the idea of even the things such as if a child or a teen is using the bathroom immediately after meals. You know, we talked about one of the eating disorders being bulimia, and that is very much a behavior that we observe. So I'm just really impressed by a couple of things. One is the eyes that schools can and do have on kids, and also how much information and how many flags we can potentially obtain early from working more closely with the schools. So that's wonderful to hear.
You know, I'll add the other side to that too, which is school can be such a great detection place and place of supporting, you know, when you have a big treatment team, et cetera. But schools can also absolutely drop the ball on this and do the wrong thing. And so this is why training is so important, and continued training. All a teacher has to do is make an invalidating comment, or a lot of people's go to snap out of it. Like, just stop it, or giving highly simplistic advice. I see educators doing that kind of thing all the time. And we have to really, really train people, not just in the detection, but how to have these conversations. You guys know better than I do the really negative impact of one false move, one bad comment, one ignoring what somebody's telling you moment, that can really, really be super detrimental.
Yeah.
So we do vignettes. When we train, we play out scenarios. I want people have to rehearse these skills. They can't just read about it or watch a video and take a quiz. That's sort of what I see, you know, improves efficacy.
Thank you. Next slide, we're moving into the final chapter of this conversation. What is the road to recovery? What are those tools that Dr. Flamenbaum just alluded to? And Liz, if you move to the next slide, we'll touch on detection, intervention, and of course, collaboration, which we just had a question about. What does collaboration look like when someone's returning back to school and then continued and ongoing? The next slide, Liz. So what does helpful intervention look like? Who says something? What do they say? What do they not say, perhaps? Denise, will you start us off with that?
Sure, absolutely. Whenever I work with families, usually what is reported to me is that if the eating disorder has already been detected, parents can often take on the role of policing food intake, and I usually hear this, and I'm the first person usually to tell them that this is typically not helpful, that there is a reason that your child has gone down this path, has developed this behavior. It is a collision of many things, but your child is using this behavior to cope, which means that something is wrong. And it's not about the food and weight. That's another myth, is that it's all about the food and weight. It's not. It's about something else that's not working in your child's life. And the best thing to do is to be supportive, loving, and check in. But not checking in about what did you eat today, checking in about how are you? That to me is usually the best place to start, to not fall down the rabbit hole and fall into the trap that the eating disorder wants you to fall into, which is to make everything about food and weight. So parents taking on that attitude of trying to really check in with their children, get to know, take the temperature, find out what's not working for them, what is their struggle, why have they fallen into these behaviors, and also ultimately adopting an attitude of flexibility, flexibility around food, flexibility around family meals, providing the safe environment that the child needs, where comments about appearance and weight are not going to be an issue. They're going to be sensitive to that. They're not going to make comments about appearances in general. They're not going to police their children about what they're eating. It's more, but they can help in a way by providing, comfortable, safe family meals, dining together, being a participant in their child's treatment without making the dialogue about food and weight.
Yeah. Thank you, Denise. Powerful information there. Dr. Flamenbaum, what is the school's position in intervention? What limitations do they have? And also how can they leverage rapport? I think that since the school is so involved in the child's life, how does intervention work? Is it directly with the individual themselves? Is it first with the parents? And I guess also I'm thinking, what kind of preparation needs to happen before intervention?
Right. Ooh, that's a lot. So I'm going to almost assume at this point we're dealing with a student that's been identified. That student has a treatment team. It's almost like assumed, because of the complexity and severity of most of these issues, that there are multiple providers on the outside who are specialists. So number one is, even us as a therapeutic school, as a clinical program, that is not our specialty. And I think I have seen clinicians, it's not their thing, but they're like, oh, I'll take on an eating disorder case. Absolutely not. So we're very clear when we first have our first meeting with the team to define swim lanes, who's going to do what. One of the things schools can do, and it's really, really, really important that it comes from the administrative level, is to understand that these kids merit a lot of accommodation. So they might, again, and some of this is coming from the physician, they might not be able to take, phys ed or swim in the pool medically. They might need to have some of their eating monitored, which we've actually been able to integrate treatment programs virtually to come in and provide a space for that. And also because much of, I mean, you know, people have heard me lecture, you know, my whole shtick is that it's axiomatic that any chronic mental health issue is accompanied by some degree, and in this case, often a large degree of executive dysfunction. So if you think about it, I mean, I'm making a simplistic but powerful point. If we can help kids with their executive functioning, which schools are in a wonderful position to do, we can actually improve treatment outcome. And it's a funny dynamic here because executive dysfunction is a risk factor to develop some form of eating disorder. It is also the byproduct of an eating disorder. And so teachers need to remember, you might have to lighten the load. You might have to give them extensions. And some of these kids are really disenfranchised because they're so high achieving and bright. They're like, oh, they can handle it. No, they can't. They have a starved brain now. A matter of fact, they're really, really cognitively very different than the last time you might have seen them. Or there's, you know, a downward trajectory. So schools can provide a tremendous amount of accommodation, and some of the intervention in terms of, think about the protective factors to support eating disorders, having good social skills. We can facilitate that. Schools do that naturally, helping out with executive functioning. There's always some learning specialists and people who seem to understand how to do that. And family connectedness, you know, really supporting the family and supporting the student and supporting the family. Like, it's a systemic issue. We can't just look at the child. We have to look at, schools can really support the whole system. Schools can often leverage too when there's resistance, which is like, hey, you want to be in school? You need to go to Monte, Nido or Balance. You need to be in IOP or residential. We're often that lever pull that can actually get the ball rolling sometimes. And most administrators are happy to play that role. They understand the power of school. But keeping kids in school is also a significant protective factor. Most of these kids and parents, as Denise, Mel, and I have talked about, they're like, look, I know my kid has a florid eating disorder, but they need to take their SATs, you know, and I get that. So if we can sort of somehow find a way to do both, I think, again, we can get kids back on track faster.
Brilliant. Yeah. Mel, can you talk about Rachel's question here, approaching eating disorders with adolescent girls on the autism spectrum? How might that differ from neurotypical school-age children?
So what we often see there is more of an ARFID presentation. I mean, I'm making some assumptions here, but statistically, we tend to see more of that sensory piece where that picky eating type of profile I mentioned earlier. And so what we can do and do is the actual treatment around that is what we call exposure therapy. So we come up with a food plan. We have a hierarchy of different foods. And there are many different techniques actually, you know, such as flavor matching is one, etc., where if a kiddo likes cheese, we can then get them to eat something that has cheese on it, and therefore expand the repertoire and variety of foods that the child or teen is eating, and most importantly, increase the calories, because often there's weight loss and we want to get them back on their growth chart. We want to get that executive functioning happening again, because the brain is impacted when there's malnutrition, as is the case with ARFID. The beauty of this, and what I'm loving, honestly, Evan, not to embarrass you, but what I love about our work with you all is how we can then integrate meal supports while the child goes back to school. So we don't have to disrupt school, because as Evan was saying, school can be so protective for kids. And so we want to do everything we can to be as flexible as we can to keep them in school, but still help them move through their treatment and get better. So, you know, how can we balance that? flexibility and having the kind of relationships that we have with you all, Evan, for example, is incredibly helpful because it's so collaborative. And so that's what we would do with, neurodivergent kids is work through these exposure therapies, have them increase their food intake, increase their variety. And also, a big tell or a big motivator for kids with ARFID is they get to a certain point in their social life, like in their teen years, where they want to start going out and hanging out with friends and eating, and they start to get to that point where it's embarrassing, or they become embarrassed that they can't eat a variety of foods. And that's often when they'll then reach out for help and support around this, so we can kind of integrate, work with them while they're still in school.
I want to add on to something you said. Can I do that?
Yeah.
And maybe it's more of a therapeutic school opportunity or ability, but with ARFID, you're using exposure response prevention, right? You're doing exposure work. So what schools in general, but we can do it, I guess, to a much more complex or intensive degree, is we can support the exposure work. So if one of these treatment centers says, hey, we're doing the exposure work. So the goal of a therapeutic school in a milieu like that is they take the skills you are working on, and then we rehearse them all day long, which is amazing. So it improves, again, by the way, I would make this trans diagnostic, whether we're talking about eating disorders or substance use or anxiety or OCD, anything that we're doing exposure work to, schools can support it and improve. The other thing is that if you want to, optimize behavioral interventions, you have to generalize skills. So you're doing it at Monte, Nido, you're doing it at Balance. That's great. You have to do it at school. You have to do it at home. I always use the example of, like, if you only teach your dog to sit at home, it's not going to sit in the park when you tell it to. So again, this kind of integration of different places, providers, and spaces really, really improves outcome. And I think anything that improves outcome with this particular category of mental health problem is super powerful. So we've had kids on the spectrum who they'll only eat white food, or they'll only eat French fries. Right. And then the specialist will set up the exposure plan. And one of our clinicians, again, they'll do it privately, carefully. You have to really respect it. But again, they make better progress that way. Yeah. It's almost like these clinicians are with them all day long by proxy.
Yeah. Yeah. Which is incredible, Evan, because that then helps in the scenario of, it means that we can get beyond the scenario of having to take the kid out of school, because they can be doing this important exposure work while they're still in school. So again, win-win, all of us coming together, thinking outside of the box, collaborating, and you being able to offer the structure to implement that kind of expertise around that particular mental health challenge. It's great.
I want to stay mindful of our time. We have 8 minutes to go to the top of the hour. So I'm going to briefly go over these levels of care for eating disorders. It's broken into 5 categories. First being outpatient, we've talked a little bit about that. That would look like someone seeing an eating disorder specific dietitian, an eating disorder specific specialty therapist. We mentioned meal supports, where a person is getting on either with a dietitian or getting on a Zoom call, let's say, or even in person with a dietitian or recovery coach to have a therapeutic meal together. And we'll talk about balance services and Monte Nido services, as we are both eating disorder treatment centers. So we'll dive a little bit into what an IOP, a PHP looks like, as well as talk about residential and inpatient treatment. But I do want to talk a little bit more about this collaboration and what support might look like, particularly in George's question about someone returning back to school from a treatment facility and what happens in that transition and therefore ongoing support. So Liz, if you could zoom along, let's say to slide 24. Thank you. You knew it. Creative collaboration. And let's talk initial steps, which is slide 25. Yeah. So here are some ways to start to address what there is and then have a plan in place. Denise, how would you frame your concern in terms of behavior and not appearance? Like, what are actual phrases to say to someone?
Well, I think that, like I said earlier, I've never seen it go well when someone uses the phrase "I'm worried about you." That usually backfires, even if it has the best of intentions. But that's why my recommendation usually is sort of a, how are you? I get the feeling you might be struggling. I get the feeling you might be under a great deal of stress. These are ways to sort of segue and lead into it, that you know something's wrong, you're not really sure it is, and you're sure what it is, and you'd like to hear from him or her what it might be. And it just opens up a dialogue. And if you want to cite behaviors, I love how this is phrased here, in terms of behavior, not appearance. There should absolutely be no mention of weight. That is going to, no matter what, it is going to embarrass the person in some sort of way. And also it's very possible that this person who's struggling with eating disorder behaviors might be dealing with a great deal of body dysmorphia, and thus whatever you say is going to hurt or embarrass in some sort of way. So I would lead with just sort of concerns. I noticed you're not seeming to really want to hang out with your friends as much as you used to. I notice you're not as interested in doing, family outings on the weekends like we used to do. You used to love to go to the movies. You don't seem to like doing that anymore. Segue into things like that just sort of the changes before we get into any specific behaviors around food. Because really what we're trying to figure out is what's not working in this kiddo's life before we get into concerns about food and weight. So that's usually the recommendation that I make. And usually I also try to make sure that the parents have a great deal of psychoeducation about eating disorders before they even attempt this conversation, because if they don't understand it, they're probably going to say very triggering things.
Yeah, it was very important and helpful. Thank you, Denise. Melainie, what kind of resources can you offer individuals?
Actually, I would like to recommend the Nido website. So Nido is the National Eating Disorder Association, and their whole mission is around supporting people who are struggling with an eating disorder and their family members and caregivers. So it's really for the individual who's struggling. So they have amazing toolkits for friends, for example, for parents, about how to approach my child or a loved one who I think is struggling. And they also have great resources about educating yourself. So as Denise said, so important for family members and loved ones and professionals, of course, to educate yourself around what an eating disorder is, signs and symptoms, etc., so that you have more knowledge as you approach this. So yeah, National Eating Disorder Association, I think, is just a fantastic place to go. They also have a hotline, so you can call them and talk to a trained volunteer, often who's had their own lived experience, to seek out help and assistance. So I would start there. And then, of course, we're always open, as I know you are, Denise. Many of the treatment centers, eating disorder treatment centers, are very willing and wanting to provide resources as well. So if you gave us a call and said, I don't know what to do, I don't know where to start, could you help me? We can also guide you through.
Yeah, thanks, Mel. Liz, if you'll move on to the next slide, I'd like to talk about each of our facilities and what we offer, and then therefore you can understand how collaboration works. Balance offers outpatient groups such as food and mood and body image. This is a weekly group that meets virtually. Also nutrition support, as I mentioned previously, meal supports and nutrition counseling, one-on-one nutrition counseling. Our programs, our larger programs include a day program, which includes group therapy as well as therapeutic meals together, and an intensive outpatient program, which is a smaller subset of hours. So it's 15 hours a week. I want to highlight here, we now have what's called a flexible virtual program. You can hold your phone up to that little QR code if you want to learn more. And the 12-day winter and spring break intensive that's about right around the corner, about to start. And the reason I'd like to highlight those is because these are programs that we have put in place to be adaptable to a hectic, full lifestyle. How can you be in treatment and be meeting the demands and challenges of, let's say, being in school? If you'll move on to the next slide, please. Dr. Flamenbaum or Liz, would you like to share a little bit about Academics West?
Hi, everyone. Yeah, we are a therapeutic day school in New York City. We go from grades K through 12 up to 75 students. We're rolling admissions. Our students work in small classroom sizes. We have about 12 clinicians for 75 students. So as Dr. Flamenbaum said, students are rehearsing skills all day long, skills that they may be have had in an IOP or a residential place. We can be that step down. So yeah, and there's all the support options and program highlights there. So yeah, that's us.
Thank you. And Liz will put her email as a contact for any information about Academics West into the chat, please. And Denise, the next slide is Monte Nido. Please share with us about the uniqueness of Monte Nido.
Absolutely. Monte Nido and Affiliates is the proud owner of Monte Nido, which is the adult division, as well as Clementine, which is the adolescent division. We are nationwide residential and outpatient programs for the treatment of eating disorders. And recently we've had 2 acquisitions, which means that now Rosewood Ranch and Walden, which means that we now actually have inpatient facilities as well, which is a new and very exciting thing for us. Before, historically, we were residential only and had to refer out for if we ever had to step anyone up to inpatient. Now we can do it in-house. So that's very exciting for us. As I said, we are nationwide. The different locations and levels of care are listed right here. What I love about Monte Nido the most is our inclusion and integration of the trauma piece. The way I was trained is there is no eating disorder without trauma. And I just love that that is a huge part of the therapy. We do CPT as a way to address the trauma piece while clients are in residential treatment with us. We also draw from a variety of different treatment modalities. And when it comes to the nutrition piece, we are all foods fit. We have a private chef in-house, which is a wonderful feature, adds to the hominess and the atmosphere of Monte Nido. You walk in, smell the aroma of home cooked food, feels great. People usually smile and wave and say hello. I absolutely love the vibe in Monte Nido because it feels incredibly warm and fuzzy. We do exciting exposures, restaurant outings, takeout nights. We also do a cooking class with the private chef and with the in-house private chef. And we also do we also include elective therapies such as art therapy and yoga therapy. We incorporate movement as well. We're on a level system, so and since we are treating all clients with variations of and various disorders and all kinds of disorders under the same roof, we accommodate for the fact that some of our clients are too medically compromised to begin at movement right away, and that's why we have the level system. So, but clients often use that as a motivator to complete their meals and participate in their therapy and participate in program as best they can so that they can work their way up through the different levels and be able to eventually incorporate movement being so important for our clients to reconnect with their bodies. We also are Haze aligned. So a feature of Monte Nido is we have mixed sized furniture, mixed size yoga mats, dinner around a dining room table with different variation in the size of chairs. We don't want anyone to feel judged or like the size of their body means that they don't have credibility that their eating disorder is active and acute. So, so these are all sort of the features that I've always been very clinically aligned with. I've referred to many a client to Monte Nido myself from my private practice, and I've always been incredibly pleased with the results. So, and also just one more thing I'd like to add is, as we all know, historically, eating disorder treatment was mostly for women, but all of our newer house openings, we've opened a great many new houses in the last few years, they're all gender. So we're very excited to be treating men and boys in the same milieu as our female clients.
Very cool. Thank you, Denise.
Sure.
Liz, the last few slides, just want to touch on some resources. Denise will put her email in the chat. If you would like to schedule a team-to-team with either Balance and your school team or Monte Nido and your school team, we offer that as a complimentary service. We're here to provide awareness and education and actionable mechanisms that you can implement into either prevention measures or supportive measures. We also have a brand new handbook for school professionals. So if you want to go to that site, you can download our handbook for school professionals, share the link with your team. And finally, our last slide is always our free support group at Balance. It runs twice monthly on Fridays and Saturdays. Saturdays with Mel herself. Open to and welcome for everyone, be it parents and loved ones or students themselves. We invite you to connect. Thank you so much to our panelists. Any final words or thoughts that you'd like to share before we wrap up?
Just great to be here with you all. Thank you, Julie.
Yes, thank you, Melainie, Dr. Flamenbaum.
Liz, for driving. Yeah.
Oh, sure.
Yes.
Thank you all. This is so great.
Yes.
I learned a lot.
Yeah,
Yeah.
great to be here. I really look forward to continued collaboration.
Definitely.
Wonderful. Thank you, everyone, for your contributions as well. This is always recorded, and you will receive the recording along with a link to where all of our webinars are recorded on Balance's YouTube channel. I hope you have a great weekend and take care.